obviously tonight we're going to be starting out with pediatrics. The good thing about this chapter is it's not as long as you would think it was. I think it's like 230 slides, but we also have tomorrow night to cover it as well. So this actually works on our advantage. I figure we get halfway through, somewhere around half. That way we can spend a little bit more time on it, talking about any of the slides, answering any questions, and then that way we can finish it and wrap it up tomorrow. So you can assume anybody that's in skills lab tomorrow morning, if anybody is, that we will be talking a little bit about some pediatric emergencies. Peds are the one thing that no paramedic and unless maybe you're a transport paramedic or a flight paramedic that primarily deals with kids, it's not a very comfortable situation to us just because we're not used to dealing with kids that often. It's not that we don't learn about them, it's that we don't have the experience from dealing with them all the time like we do adults, and that makes us a little bit uneasy, and that's normal. That's fine. But there are some basic things that we have to understand, such as vital signs of kids are different medical conditions that kids can have, different ways they present, different ways of assessing kids. Just because might not be able to ask them what's wrong, we might not be able to know that they're in pain. We might not be able to know they have trouble breathing. So that's all stuff that we have to kind of tailor to fit each certain situation, and really be able to adapt and learn a little bit as we go as well. Obviously, children's anatomy is a lot different than adults. Adults were a lot more set in our ways, if you will. We're grown, right? We don't have these growth spurts. Our bones are hardened. We have cartilage, all this stuff. That's where kids really don't have that. Even when you're starting to talk about their airway, their tracheas, they really don't even develop those cricoid rings that you feel in your own windpipe until later on. The issue with that is that something that might affect an adult might not affect a child. Kids are really resilient, especially infants. Newborns are really resilient to anything that might come at them trauma-wise as well. So just something to think about is what anatomy differences could we essentially run into. Children also look at things differently. An adult looks at a cold as, great, I've got a cold, maybe, okay, I might get some cough drops, I'll go to work, I'll tough it out. Kids don't see it that way. It's the end of the world, right? And again, they can't tell you what's going on. They can't tell you I have a sore throat. They can't tell you if it just kind of feels like the common cold, or it feels like the flu again, or something like that. Kids are also frightful of everything. If they're not, then everything kind of excites them. Their
Hey, Rudy.
emotions are, yeah, go ahead.
Sorry. Sarah had just called me and said there was a couple other people, Andrew and herself, and some other people that were in another group. I just sent them out an invite, just to let you know that.
Oh, that's fine.
Okay.
Kids also have, a fear of what could go wrong with them. So, if they're sick, again, that might be the end of their world. As opposed to us as adults, we kind of learn to get through it, right? The other thing that we have to look out for with kids, especially newborns, is parents, right? That's why one of the biggest things I always hit at is if you're dealing with somebody that's a first-time parent, you almost have to kind of comfort them as well. Because when the kid starts to see the mom freak out or the dad freak out, the kid starts to freak out a little bit, right? As opposed to seeing us all kind of calm, cool, and collective. They're not as easy to get worked up in that situation. Let me see if they joined real quick before I keep going. We're going to give it just a minute here to see if they hop on real quick. I think we're only missing 3 of them. Was anybody in here in the other, like started another chat and then realized that this one was ongoing?
I was.
Okay. How many people were in there with you by chance? Do you know?
There were 3 or 4 others.
Okay. So we're just missing a couple still. So we'll give it 1 second, wait for them to join, and then I'll kind of carry on since I haven't really gotten any meat and potatoes yet. Do you guys not have the Teams app by chance? Are you guys just clicking on the link that I send out for class?
I've got the app.
I click on join in the calendar
Yeah,
usually.
mine shows up in Teams.
Okay.
I do calendar.
Okay. The only reason I ask is like if I put chat notes or something in there like that, then I wasn't sure if you guys got those or how that worked. Hey Tanya, can you check with her and see if she needs
Yeah, I
help
just
getting-
sent her another link actually in a text conversation, and I told her that the way that I get on was just to go through Office 365 and then go to your calendar, and there's a link on there to whatever meeting is scheduled for the time. But yep, I will check with her real quick.
All right. Actually, I just saw another couple people get on, so I think we're good to go. All right. Sorry for anybody that got on late. I apologize. I know I had sent that email and then I messed up and created the wrong event. So then I hit cancel and it cancels it. But unless you have the app, you don't know that it's canceled because it just sends you another email for a different link. That's the only reason I asked about that.
We're good.
All right. Vital signs for kids, right? This is the first group we're going to look at. Neonate and infants. Neonate, first month of living. From the time they're born to the time that they turn 1 month old is considered a neonate, as opposed to infancy is up to that 1 year mark, that 12-month mark. Some of the things that we will start to see in that time period, right? We will start to see the child begin to recognize things. They'll start to recognize caregivers. They'll start to recognize feelings that their caregivers give, such as if their caregivers are worked up, or if their caregivers are stressed out or anything like that. They may understand that as something is wrong. You know, I have a newborn nephew, and I've actually been to my brother's house, kind of holding him and just watching him and all that. And you know, the first couple weeks after he was born, you know, kids sleep. That's when they're that young, they sleep the whole time, right? As opposed to even now, just being almost 2 months old, he looks around a lot more. He starts to take in things. You know, he's now starting to recognize things. He can recognize his parents. He can recognize people he's around consistently. And that's something that happens over time, right? Now, us as adults, we don't remember anything from that period. We don't remember anything from when we were 2 months old, but it helps them in their lifespan development. Obviously, they're going to be, depending on what child number this is for the parents, there can always be things that are expressed as concerns that might not truly be concerns, but that we can help them out with, such as, you know, their behavior. Maybe the kids have a feeding problem. Maybe they're not falling asleep at night, so the parents think something's wrong. Or, you know, the kids sleeping too much and the parents think something's wrong. So those are things that we should all kind of be paying attention to or watching out for. And again, these kids are generally pretty resilient. And obviously looking for any sort of signs of abuse as well. And I hate to be that way, but if it comes out as a traumatic injury to a kid that small, that's a red flag, in my opinion, that something's wrong, until I can get there and assess the situation, the scene, and the patient themselves to kind of learn what's going on. Kids can't maintain their body temperature all that well. That's why, you know, when you see kids swaddled up or they're in a onesie or in some little outfit, whatever it may be, and then they have a blanket on top of them, and then maybe they have a stocking cap on them, that's really just to help to retain their heat. It's not because we're trying to keep them, you know, or raise their temperature up or anything like that. We're just trying to maintain their temperature, what they have, just because they haven't really developed that process like we have, where we can fluctuate our body temperature. And that's a very good reason why kids, you know, when they start to develop a really high temperature, they can develop a seizure condition, febrile seizures, just based off of, again, their body not being able to auto-regulate that. They also don't have the neck muscles when they're that small that they would as an adult. You know, we want to make sure that we're watching their head, watching their neck, make sure there's no extension, no flexing that could potentially hurt the kid. A little bit older on with infants, it might be not so much of a bigger issue if you see they are supporting their head on their own. But again, that's something just to watch out for. A quiet child is concerning, yes, I would say, but I also base it off what the parents, what's the kid's normal. You know, I don't go in and say, hey, textbook says your kid's quiet, something's wrong. No, I base it, hey, you know, is this, does it seem like they're acting normal to you? You know, are they able to track you with their eyes? Can you wake them up? Things like that. Those are things that I'm checking with a kid as opposed to like an adult. Remember, our hands, when we're assessing these kids, can be really cold to them. So if you can, you might see some people like rub their hands together, warm up their hands just before they're touching them. That way it doesn't freak the kid out. Use a soft voice, not a, you know, a really booming voice. If you need to quiet the child while you're assessing them, maybe they're crying, try using a pacifier that, you know, that, or, you know, try to distract them a little bit if you can. Maybe it's using a pen light, maybe it's, you know, dangling something in front of their face, whatever it might be. Just don't put something in front of them that obviously there's a fear that they're going to aspirate it. Toddlers, this is what I call the fun age, 1 to 2 years old. This is really where, you know, kids are starting to learn to walk and trying to, you know, they're starting to explore things. They're starting to eat different foods. They're no longer, you know, on formula, they're no longer straight on just baby food or whatever it might be. Now they're kind of exploring different things. They want to climb over things. This is where we start to raise the crib height in the bed. This is where we get a little bit more concerned about them grasping things and picking up onto things. We start to lock things up in houses. You know, we put locks in the fridge, we put locks on all the cupboards just because we're concerned. Depending on the age, you know, it says right there, head grows more slowly than the body. To a point, yes, but kids are also very top heavy. That's why when, you know, we do infant or child CPR for your BLS certification, we always try to pat underneath the shoulders just because kids have giant heads. Kids will also start to develop their personality at this point. This is when you'll understand what makes them laugh, you know, what kind of things they think are funny. They'll be able to move their body parts a lot more freely. They'll have more control over things. And they start to try to form words at a later age, even though they don't know what they're forming, but they've picked up on things we're saying and they're trying to mimic them. They don't really have problem-solving ability, I should say, but they're trying to mimic what they see around them. I understand 2 years old, we call it the terrible twos. It's just because that's when they're getting their personality. We tell them no, they want yes. They're not the happiest about it, right? This is also the age where kids might start to remember stuff. I know we learned about the pediatric assessment triangle previously in class. Am I saying I use the pediatric assessment triangle when I assess a kid every time? No. Does anybody remember what 3 things we look at for the pediatric assessment triangle?
Is it appearance, breathing, and circulation? Or color?
So yeah, appearance, work of breathing, and then yeah, circulation, color, stuff like that. So it's really ABC if you think about it, right? It's pretty easy stuff to pick up on. What's the number one issue that kids have? What's the number one thing we get called for with kids? Would you say?
Choking.
Okay.
Respiratory.
Right there, respiratory. Generally, respiratory problems are what we respond to the most, and choking is a big one, especially for smaller children. And that could be even just, you know, whether they're breastfeeding or formula fed. A lot of kids, and my nephew had even done it once when I was over there feeding him. He started to choke. You know, he sucked in air automatically and then like stopped breathing. And my brother's freaking out. But again, I'd been around my other nephews. My brother was a lot younger and everything like that. And one of the things I did was I blew into the kid's face. It freaked him out and he regained his breath. It's some stuff like that the parents might not know what to do. And I'm not a parent, but I've been around enough little kids to know that. So when they're calling 911 for these things, it's an emergency to them. But to us, we still have to hold our composure and we still have to act like we know what we're doing, especially if we don't deal with kids all that often. When you're going to assess a kid, I wouldn't necessarily say examine them on the parent's lap, but if that's where they're more comfortable, then absolutely do it. They're going to be more comfortable in the presence of the people that they know, as opposed to ours. You know, getting down to the level, they might be frightened by somebody that's standing above them or that's large in stature. Like me, kids right in the beginning think I'm a terrifying person. I'm a big, large man, right? To them, that's scary. Have the parents there if you're going to assist them. Be willing to adapt and change your assessment based off of what's going on with this kid. And that's when we say be flexible, you see there. That's really having the ability to say, okay, I'm not too concerned about this, or I can't assess this because the kid, and I'll be honest, even some children now, I take them, if I transport them or whatever it might be, you know, an adult, if we let them refuse, we get a full set of vital signs. On a child, if what I'm going to do is going to piss them off and make them start screaming and crying or whatever, I probably won't do it. You know, I'm probably not going to get a blood pressure. If maybe this was a, hey, he was choking on some formula, I'm sorry, we called, something like that. I'm going to check him out, make sure he's acting appropriately according to the parent standards. Make sure that I don't see anything in his mouth. See if I can get any emotion out of him. Maybe it's, I don't know, tickling them or making them laugh or something like that, because then that tells me that they're they have the ability to kind of, you know, change their emotions, and that they're just kind of frightful of me being there. That's what I mean when I say be flexible and adapt to what you're used to doing, and kind of take it out the window and throw it out and redo everything. Kids are a totally different animal, and assessing them is way different than we would with anything else. Age 3 to 5. This is when we start to become a little more verbal, right? We start to become a little more active as children. We're starting to go to school at this point, maybe. They can understand basic general directions. And this is where they'll be able to start to tell us what's wrong. You know, if something hurts, or if they fell or something like that. You have to speak to them like a child, though. You can't speak to them like an adult. Don't say big words that they're not going to understand. You have to choose your words wisely, essentially. At this age, kids are also very curious. They want to explore things. They want to figure things out. They might not be the best to want to cooperate, but generally they will. Be respectful of them. Kids this age also want respect, and they don't honestly know that, but treating that way is going to gain you brownie points, to be honest. When I say that kids are curious, if you're assessing this child, I don't care what you have in your bag that the kid isn't going to mess up or get hurt with. Let them play with it. It'll distract them. They're curious. They want to mess with things. They want to look at things. They want to see things they've never seen before. Let them play with something, just to kind of get their mind off things. If you're going to ask them questions, again, break it down to their level, to something that they might understand. If you have kids who are used to doing this now, look at their behavior and understand that some of it might be normal, because this isn't a normal situation, especially if an ambulance is there. But set a threshold in your own mind about what is normal for this, you know, for this abnormal situation, and what is abnormal for this. At what point do you start becoming concerned as a EMS provider? Uh, 6 to 12. These are the kids that are kind of mean, to be honest, in my opinion. They understand cause and effect. They understand, if you do this, this is going to happen. If I knock the glass off the counter, it's going to shatter. My parents are going to be mad. They understand that. School is really big for kids at this age. They either enjoy it or they hate it. There's no in between of, I'm getting by. No, they either like it or they don't like it. Especially if it's, you know, children have been bullied at school, or kids that have any sort of disability or something like that. They can be a little bit self-conscious about themselves or about things in general. So just make sure we're treating them appropriately, and we're not, you know, making them feel substandard or anything like that. They also might have their own understanding of what medical care is and what an ambulance truly does. You know, this is the age where kids can see ambulances driving by. They can see them when they're sitting in their car. They can see them when they're at their front window of their house. They might think that we are either just people that drive people to the hospital, or, you know, even might think that we only help people that are dying. So this is also the age where we can kind of make a little bit more of an impact. You're also going to start to see anatomy growth at this point. You know, I swear to God, as generations go on, people or children are growing so much faster than when I was younger. I mean, and when I say that, I mean, yeah, how do I put this? Going through puberty faster is what I'm getting at. Think of like females. Generally breast development is between that 8 and 13 range, and you're starting to see it a little bit faster. Menstrual period, all these sort of things. This is also when we talk about that 12-year range, they're starting to become self-conscious about themselves a little bit. One more year and they're at 13. They're technically a teenager at that point. They're going to be a little bit self-conscious about themselves and what they're seeing at school and what they think they should be acting like. These are the ones that we're going to have a hard time with. And it's not because they're hard to assess. It's because they're hard to answer questions or don't want to deal with us or don't want to answer questions. Because really this is when 13 to 18 is really when they want independence. That's what they're seeking. They want, a social life, but they also want to be able to deal with their own personal issues that they have. If you've honestly noticed that, I don't know, maybe they're the size of an adult, in my opinion, treat them like an adult, because that gains you respect from them. And I'm not saying that we have to earn their respect or anything like that, but at a point we do, because if you want to find out stuff, you've got to kind of do that, right? Especially when we start talking about like CPR or anything like that. I don't go based off age. I go based off of size, just similar to the Broslow tape, where like we would for a smaller child. It really just depends on what I see when I get there. Reminding them, again, 13 to 18, that you're not a police officer, that you don't care what they've done, that you're there just to help them. Encourage them in that aspect. Kind of joke around with them, kind of get down on their same level. I kind of look around the environment that I'm in, whether it be their house, their car, whatever it is, and I try to identify with something that they have, and then just try to make a small conversation based off of that, because I feel that if I can do that, they might trust me a little bit more, to be honest. If possible, I'm not saying this is 100% the greatest thing to do, but try not to have the parent or whoever, or guardian, whoever there, just because they'll feel like they have to lie if something is not what they want. They don't want their parents to find out, especially if it's a female and we're questioning about pregnancy. Try not to have parents around, because we really want to know the truth, as opposed to just what the parents want to hear, and they might not feel comfortable saying some stuff in front of their parents. Some things that we should obviously, some anatomy changes that we're talking about with children. Infants and young children's heads large relative to the rest of the body. I talked about that. Their heads are massive. About 2/3 it's adult size, so their head is huge compared to what the rest of its body. What that means is, in trauma, where can we potentially see the most injury? The head, right? It has a large surface area compared to the rest of their body. So in traumatic situations, we try to look at their head a little bit further. Does anybody remember what the soft spots on top of an infant's head are called?
Fontanelles.
Fontanelles, right? Why are the fontanelles important for us as EMS providers? What can we tell based off their fontanelles?
You can tell if they're dehydrated. It'll sink in if they're dehydrated.
Okay, what else?
Developmental reasons. I mean, if they're not properly formed.
Okay. I can tell formation, right? Like you said, I can tell if they're dehydrated. I'm looking for that sunken fontanelle. I can also tell if there's any sort of brain swelling, because I'll almost see bulging out of that fontanelle at the same point. If there's any sort of suspicion for a traumatic injury, I could see that as well. Be careful when you're positioning the airway of these kids. Again, they're really flexible, yeah, but there's a potential to harm them. If we're going to have to place pads under their shoulders, again, it brings their trachea more in line for us to be able to control that airway if need be. Kids, short, stubby necks. That's why we check for a brachial pulse. When we talk about like CPR and stuff like that, we check for brachial pulse in those kids. They got little fat necks. They got baby fat, right? It might be really difficult or hard to palpate the jugular vein if that's what you're going for, or carotid artery. Airway in correlation to an adult is way smaller, which means that in a foreign object that might not affect an adult can affect a child. What that also means is we're a little bit concerned about possible inflammation from maybe something as simple as let's say, bronchitis or asthma. Becomes a little bit more of a concern. Think of a regular sized straw diameter to a coffee straw. That's the difference that I'm talking about. Kids also have a disproportionately large tongue. So tongue is also a concern when we're talking about airway management and making sure that we don't have any sort of obstruction. Pretty early on, kids are nose breathers. So making sure that we keep their nose clear because they'll feel like they can't breathe if we don't. Pretty important, and this could be a national registry question. I know I've had it on different test questions that I've taken or tests that I've taken. Narrowest part of a kid's airway, a young child's airway, is the cricoid cartilage. That's the narrowest portion that they will get to, below the vocal cords rather than at the vocal cords. An adult is at the vocal cords. Kids are below the vocal cords. So that might change our idea of what size ET tube we're going to use if we're going to look at, endotracheal intubation. So as adults, average, let's say lung capacity wise, for an adult, 500 to 600 mLs of air, roughly 5 to 6 liters. A kid is a lot smaller than that, right? So what does that mean when we talk about tidal volume? Are they going to take less breaths? Are they going to take more breaths? What do you think? Why does a kid that's younger breathe a lot more than somebody that's older? It is because their volume is slightly smaller, but their oxygen demand is higher. Kids' metabolism is off the charts, so they need that oxygen, right? They're growing. Well, we don't have the lungs to bring in that much air, but we have the ability to speed it up. So that's why kids breathe faster, is they're not bringing in as much air with each breath, so they breathe a lot faster. As you can see, as they get older in that chart, their breathing starts to slow down because the lungs begin to develop. The lungs start to become a little bit larger. They can bring in more air. They can bring in more oxygen. Their body can now meet those metabolic needs that it has for oxygen in itself. This is pretty important. And again, this PowerPoint's going to be online for you guys to watch later on, but making sure that you know this little chart here. If you got to take a picture of it, whatever it might be, I'd pay attention to it. I can go back if you need a picture of it. If not, let me know and I'll make sure I get a file posted online that you can view. So infants and kids a lot more susceptible to hypoxia just because of, again, their decreased lung capacity, along with their increased oxygen demand. If we take the oxygen away, their body still craves that much, but we're not putting it in. So the kids are technically going to crump faster. They'll compensate for so long before they really start to go downhill. Their respiratory muscles are easily fatigued. That's why kids that are having trouble breathing, you'll start to see, their nasal flaring. You'll start to see intercostal retractions. You'll start to see their belly move up and down really rapidly. Those are the muscles that they are not normally using for breathing, but now they're using accessory muscles to help them breathe. Again, they'll ride a roller coaster for so long, wouldn't be hypoxic, and then they'll start to go downhill. This should also play a role in how we are bagging these patients. There's a reason that a BVM is a lot smaller for children. It should not take the whole BVM. If it takes a whole squeeze of a BVM to get the chest rise, you have a bad seal or something else is wrong. It should not take that much air to get chest rise out of a child or an adult for that matter, to be honest. Another chart that we should probably know, heart rate for kids. So again, kids' bodies are a lot smaller. Why does their heart beat faster? Well, it's because they rely on it. They rely on the pulse to maintain adequate cardiac output and compensate for decreased oxygenation. That's why their heart beats a little bit faster. That's why when we grow, our heart rate starts to slow down a little bit. So, let's look at that neonate, 0 to 1 month of age. A sleep heart rate can get up to 160. Well, if I don't know that, I go up to, or even their awake one goes up to 205. If I go up and, put my little pediatric pulse ox on them and I see a heart rate of 150, without knowing that, I freak out, right? That's not tachycardic to them. That's normal. That also plays a role in if we are looking at a cardiac rhythm with these kids. What's sinus tach for an adult isn't sinus tach for an infant. So heart is obviously a lot more limited than adults, right? It's still growing. It's still developing. It's like kind of like a brand new car that just, they just came out with. There's still some bumps that it has to overcome. There's still some things that it is learning, right? Injured kids maintain blood pressure for a little bit longer periods than adults, even though they're in shock, just because proportionally they don't have that much body as opposed to adults we do. They don't have that much circulation inside them as opposed to adults we do. That's why they can maintain a little bit longer in shock than we can as adults. Whenever there's, tachycardia, we start to become a little bit concerned if it's outside of the normal range for them. If it's outside that normal, let's just say that last chart, 160 to 205, it's outside of that, we start to become a little bit concerned. At that point, you should be looking for, is this potentially compensation for something? Is this kid potentially in shock? Those are things we should be paying a little bit of attention to. Bradycardia. Bradycardia can usually indicate that a kid is hypoxic, because again, hypoxia will occur before the heart starts to shut down. And that's something we might need to manage a little bit aggressively, whether it be fluids, whether it be medications, kind of figuring out the problem a little bit faster. By the time you start to see hypotension in a kid, it's a pretty late sign. They've compensated for so long, they're going downhill. Unless you do something quick, they might go into irreversible shock. At that point, we might be resuscitating more than anything if we fail to act at that point. Cap refill. Cap refill is huge in kids. Generally, that 6-year and below range. Anything greater than 2 seconds could indicate that they have poor circulation. Could be dehydration. Has the kid, again, had, what have their diapers been like? What have they been eating? What have they been drinking? Have they been sick recently? These are all questions we should be asking. So, when looking at a kid's heart, during the first year-ish of a kid's life, their electrical impulse within their heart starts to change. Remember we talked about axis deviation in adults, 1 in ABF, or what we look for on a 12 lead. In a kid, it will start to show left-sided dominance more than anything, because they don't have the muscle built up that adults do. And the left side's working a lot harder than the right side. So it will naturally show left axis deviation in kids. So that's something just to be cognizant for. Their cardiac output is dependent, or output is rate dependent in infants and young children. Absolutely. It's because they don't have the ability to increase stroke volume. They don't have the ability for enzymes to be released to push more blood out, for their heart to contract harder. Mediastinum is more mobile, so the middle of their chest. Yeah, absolutely. They're not fully developed. Their bones aren't hardened like ours. But what that means is they don't have the protection that we do. Our rib cage and our sternum really protect our internal organs. Kids don't necessarily have that protection. Nervous system with kids is a lot different as well. And it continually develops throughout the kid's childhood. Brains are a little bit smaller, so the space surrounding the brain is a little bit smaller, which means that swelling could show up a little bit faster. Brain and spinal cord aren't as well protected. Absolutely. Again, this goes back to bones not being fully developed. But their brain requires nearly twice the cerebral blood flows in adults. Again, their metabolism, right? They need more oxygen. They need more glucose. That's why kids eat so many times during the day. Is their body needs it. It's starving. It's like an engine needing fuel. it's through a kid's lifespan development, through a child's lifespan development, you really start to see their brain develop. And even not physically, you start to see anything that they learn anything new they learn, as I sit here and have a stroke, anything new they learn is their brain starting to develop. Anytime they pick up something new, their brain is recognizing. Anytime they look around, their brain is processing it and storing all this for information. You have to think they're a brand new computer that we are starting to begin to store information on. Brand new out of the box. Kind of cool to think about. Spinal column. A little bit higher where the spine connects to the skull, just because the head is a little bit heavier. Fulcrum, the point where we start to pivot our head back and forth, develops around C5 or C7, if I'm not mistaken. Why that makes a difference for us is because infants that sustain any sort of like blunt trauma to their head, they're at a high risk for cervical spinal injuries, as opposed to children will likely sustain a lower cervical spinal injury, which could lead to paralysis. So infants, we're more concerned about high up spinal injury. Children, it's going to be a little bit lower because their body's starting to develop. Their body's not as small in comparison to their head. So things start to kind of move down a little bit. Abdomen and pelvis, susceptible injury, absolutely. Their abdominal wall is really thin. It's not fully developed again. Organs are a lot closer to the surface. They don't have a ton of body fat, right? So there's not a whole lot to protect them. Kids' organs are generally proportionally a lot bigger in size than anything else. They don't have abdominal muscles. They don't have any of the muscles that we would have as adults. You got to remember, they're just starting to develop some of this stuff. Any sort of distension in a healthy infant could be due to larger organs, to be honest, or weakened abdominal muscles, because again, they haven't developed yet. Kidneys on the back, the posterior side, right? They say retroperitoneal. Kidneys are more vulnerable to injury. Just because the kids are a lot more mobile, they're less well supported, and the lower ribs really aren't developed to help support and protect them from an injury. So something to think about as well when you think about lower back injuries in children. So adult height requires bone growth. Absolutely. We have to have a growth spurt, right? We have to have these growth plates. These growth plates are made of cartilage, fairly weak, right? That's when we talk about like green stick fractures. I think I had mentioned that at one point, where it's almost like when you take a branch or a tree limb or something that isn't dead and try to break it and it splinters more than anything. That's when we start to see these because, again, they're really softened bones. Generally, kids don't generally present with like any sort of dislocations or anything like that. And once we start to get to that 12-year to 13-year age is when our growth plates slowly start to close. We can have growth plate fractures, which can be a concern, but generally it's going to attack something first. Something else will break before the growth plate will. Immobilization should be the same as it would with an adult. Obviously, our equipment might have to be a little bit smaller based on the size of the child, and really assessing them and the anatomy based off of where they were hurt. We're going to jump past that. All right, chest and lungs, right? Chest wall, real thin. Again, they don't have that really thick rib cage to support them. They don't have the diaphragm muscles that we do as an adult. They don't have the fat that we do as an adult. Okay, that means that we have a potential for a little bit higher index of lung injury. Our suspicion of index is a little bit higher for lung injury with these kids, just because they don't have the protection that we do as an adults. And that could be, a flail chest. That could be a pneumo potentially. Even something as serious as cardiac tamponade, we could think about. You remember, muffled heart tones, narrowing pulse pressure, jugular vein distension. JVD is going to be a really late sign of cardiac tamponade. That narrowing pulse pressure is actually one of the first things that you're going to see in tamponade itself. The other thing is if we have to bag this kid, right? They don't have the lung capacity that we do, right? They're really small. They don't have the lung lining that we do. It's really thin. So their lungs are more easily ruptured, especially if we're delivering too much air. So we got to be really careful of that. Skin. Kids have thicker or thinner and more elastic skin, right? Heads, massive. They have a higher body surface area, weight to weight ratio, less fat tissue, less subcutaneous tissue. Now, burns. Let's talk about burns in infants and kids. Burns that are generally minor or moderate for adults are considered severe for children. So something that might be a first degree burn for an adult could end up being a third degree burn for a child, just because they don't have that really thick skin that we do as adults. There's a reason that we keep, kids, if you take them outside or something like that, we try to keep them in the shade. We try to keep them in their stroller with the little hood up or whatever it might be. Kids also have an increased risk of hypothermia, right? They can't auto-regulate their temperature. They don't have that thick skin to be able to do that. They don't have the body fat. So things to consider as well when you're talking about environmental emergencies with these kids. Metabolic differences, right? How do we metabolize things? Kids' metabolism is super, super fast, which means they burn through a lot of sugar. So hypoglycemia is a thing in children. That's something we should check if there's ever a question as to what is causing what's going on. Check a blood sugar, especially if we're talking about seizures, right? We go, we have a kid that's seizing, non-febrile, so there is no elevated temperature. We should be checking a blood sugar, and that goes for adults as well. Generally, if a kid is injured, majority of them will have at least some sort of caregiver present, meaning, again, you'll be dealing with more than one patient because you're also going to be talking to the parents while assessing your patient. And it's going to be stressful to the parent unless they're like 6 kids in. My little brother was kid number 3 for my parents. And I swear to God, me and my older sister ended up at the hospital for everything. My brother, they basically told him to deal with it or get over it or whatever it might be. He didn't have the niceness that we did. But what's important about this is establishing a rapport with the caregivers. The parents have to trust you just as much as the kids do. Use the parents for information, just like we would a witness for an adult, right? Watch the reaction of the child when the parents either talk or how they act. Excuse me. Make sure that you're explaining what you're going to do to the child, especially if you're going to be starting an IV or giving any meds or anything like that. You might have to advise them a little bit more as to what you're doing or what your medication does or why you're doing what you're doing. And if you're going to transport them, if you're going to transport the kid, transport at least one parent with them, just to keep them calm. I mean, nothing's going to freak a kid out more than being in the back of an ambulance with a bunch of strangers facing the wrong way to where they can see cars going down the opposite, going how they've never seen them before. That's all stuff that kind of freaks them out a little bit. Just be patient. That having patience is really key with kids. Parents are a patient, right? I mean, we don't have them sign refusals or anything like that. But first priority is the child. Don't let a parent that's aggressive or distraught or freaking out interfere with your care with a patient, especially if you think it's needed. Have other family members, help calm them down if you need to, and try to explain to them what's going on. Maybe this is something that you've seen a couple times. Talk them down. Pediatric assessment triangle, right? Pediatric patient assessment. That's how we're going to assess them, or PAT. Parents, work of breathing, and circulation. So ABC, when you think about it, it's a little bit different from adults because RA is airway, right? Their A is appearance. Everything else is pretty much the same. Have age-appropriate equipment. Everybody has a PEDS bag. Like I know my cardiac monitor has a little PEDS pulse ox in the back that either I'm going to put on their toe or I'm going to attach to their ear or something like that. Small blood pressure cuff, small stethoscope. Small arm boards, just simple stuff like that. So primary impression or primary survey when we come to them, one of the most important factors is what we see when we actually get to the patient. We should be able to tell a lot. We can look at adequacy of ventilation. We can look how they're breathing. Are they using the accessory muscles? We can see their color. We can see if they're sweating. We can see if their eyes are following us, right? There's a mnemonic that you can actually use. It's called TICKLES, and it's TICLS. And TICKLES stands for tone, interactiveness, consolability, look, and speech or cry. Think everything we do with an adult, we can do for a kid, right? We walk in, we see an adult, and we start to paint our bigger picture at that point. Do the same thing when we're looking at a kid. Find out what is normal for the kid. When I worked for transport service or interfacility service, we were at child serve a lot up in Johnston. And so we got to see a lot of sick kids. Well, knowing what is sick versus what is normal for them plays a huge role in how you treat them and what you're going to do. So again, try to find out normal for the patient. All right, we got 10 minutes and we're going to take a break. Work of breathing. What does it look like? What do you hear? What do you see? Do you hear abnormal sounds? Just like an adult, snoring, muffled or hoarse speech, stridor, grunting, or wheezing. What do we notice about how they're breathing? Do we see intercostal retractions? Do we see head bobbing? Do we see belly breathing? Do we see flaring of their nostrils? Does the kid look like they're in distress? Sometimes just visualizing them can be a better assessment in kids than actually listening or counting a respiratory rate. The parents, again, will know, how long has this been going on? That's one of the questions I want to know, because I want to know how long they've been compensating. Why is that important? Because I want to know, do I have an exact number? No, but I want to know if there's a potential that this kid's going to crash on me. And there's always that potential. Remember, stridor, that high-pitched wheezing sound, is indicative of an upper airway obstruction. Snoring, muffled, any of those could really be croup, maybe some sort of upper airway infection, RSV, airway swelling. Those are things that we all need to kind of pay attention to, especially when we start to talk about resuscitation of these kids. And we'll talk a little bit about that during ECLS. Wheezing, a lot of kids have asthma. Wheezing is a really big indicator that kids have asthma, especially if you get called late at night or in the early hours of the morning. I was a kid that struggled, suffered really bad with asthma, and I didn't always have a nebulizer handy or the treatments to be able to get a nebulizer. And I remember my mom taking me into the shower with the steam going and would just sit there with me. And I'd constantly just cough up phlegm because the steam actually helped open up my airway. Or we'd go sit outside when it was really kind of chilly out. I'd say springtime, kind of like it is now, 50 degrees in the morning. And there'd be dew on the grass, and the cool air kind of helped me breathe a little bit. So the reason I say that is because that's the most common time for those kids to really start to have any serious problems with asthma. Primary survey, here you go. I don't know what else to hit on from primary survey that we really haven't already gone over. Obviously, based off what you see with what you note as well, as far as work of breathing, it's really going to suggest how severe their problem is, and really indicate to you that the problem is of respiratory origin. Circulation of skin, right? Color is a big thing that we should be looking at. Do you see any modeling? Do you see any blue? Any cyanosis? It might not be the greatest sign, but it's the first thing we see. It's the initial thing that we look at when we come into contact with a child. Modeling could, indicate hypoxia, could indicate a blood problem such as anemia. It's really when our blood vessels start to become hypoxic as well. It could be a response to an environmental change. If it's really cold out, really cold environment, yeah, you'll start to see modeling. Cyanosis, cyanosis, really big indicator that our kids aren't getting enough oxygen. Blow by oxygen does wonders. Kids don't want a face mask strapped to their face, and they don't want a nasal cannula up their nose. But they'll take that little teddy bear you're going to give it with a nasal cannula, with your oxygen tubing taped to it, and hold it while they could receive oxygen. Or if parents can hold it near them, just so they can get some sort of blow by. Make the decision. Are we staying and playing, or are we going? This is all based off your primary assessment. What do you see with the kid? Address our ABCs, and then address your pediatric assessment triangle ABCs. Life threats come before anything else, right? I can't go to control an airway if I haven't even seen the kid yet. Don't assume the worst just based off a dispatch. Well, I shouldn't say that. Assume the worst, but prepare for the best is what I should say. Don't go in there guns blazing until we truly know what's going on with the kid. History is going to be generally pretty short, especially I'd say on 90% of our patients, especially when we start talking about medical history, as far as history of conditions and medications. All right, let's go ahead and take a 10-minute break now. So we'll say at 7:05, we're going to come back here and keep going through our slides. All right, let's keep going. So hands-on with these kids, right? We're looking at potential injuries. We're looking at completing our full primary survey if the need arises that we have to do a hands-on survey with them. Estimate child's weight can be a little bit difficult, hence why we use what you see in that picture there, the Broslow tape. There is no replacement for Broslow tape. Don't even try. You know, an adult, you want to try to guesstimate how much they weigh, that's fine. Maybe you're going to give fentanyl or whatever. I get it. On a kid, I don't do that. Use the Broslow tape. Or if, you know, parents said, oh, he was at the, just at the doctor yesterday or something like that, they'll know how much he weighed. But again, just to be definitive, I would use a Broslow tape in my opinion. It kind of covers some bases as well. You'll see it called the pediatric length-based resuscitation tape, not necessarily Broslow. But it's going to give you all your medication dosages. It's going to give you all your sizes of medication, such as ET tubes, NPAs, OPAs, whatever it might be. I know, like my service, our in our peds bag, that's the very first thing when you open it that you see is a Broslow tape. Some of them are color coded, like I know mine. I have packets in there that are color coded based off of what color that kid is, off size. I grab that color. It has a card in it that tells me my dosages. I mean, it tells me everything. So just kind of depends what your service has. Airway. Okay, determining whether this kid has a patent airway and adequate chest rise and fall with each breath. Kind of important. We're also looking to see if there's any sort of potential obstruction, right? Is this an incident of a kid choking? Is it an incident that parents called because the kid was choking on formula? Or kids not acting right, kids having trouble breathing? Those are all things we should be checking. Kids, if we have to suction them, don't keep the suction in for too long, just because if they vagal down, they're already hypoxic potentially. It can actually cause them to potentially go into arrest. They're really, really sensitive to vagal stimuli, and you'll start to see their heart rate, drop really fast. Breathing. What did we notice in our primary survey? How were they breathing? Did we see those intercostal reactions? Did we see accessory muscle breathing? I'm not saying count breaths for 60 seconds. Count for 10, multiply by 6. It's fairly simple. Note if you see any periods of apnea, right? That should be, say a kid's respiratory rate's 30. We'll just say 35, 40, something like that. Ask, mom, how long has this been going on? Again, I want to know how long the kid has been compensating. Respiratory rates can be indicative of many things for kids. Pain, fevers, anxiety, excitement. Kids can, start to freak out a little bit. Listening for breath sounds can be a little bit difficult, especially with kids, because they don't want you to listen to them. They might be trying to move around. They might be kind of freaked out. You might have to determine where the best place to listen is. You might be kind of listening around a little bit before you really start to hear any of those breath sounds that you're looking for. Use pulse ox, but use it in conjunction with your primary assessment, right? We're looking for 94 to 99%. Use end tidal as well. Same measure, 35 to 45. But don't rely solely on end tidal is my big thing that I'm hitting at there. Circulation. Again, check a cap refill. We want 2 seconds or less. What does their skin look like? Do they have that modeling? What does their heart rate feel like? Does it feel rapid? It's gonna, no matter what, I guess. Does it feel bounding? Does it feel weak? Then maybe put them onto an actual pulse ox and see what number you're getting. Try to get a manual pulse if you can. It seems like we've kind of gotten away from that, but manual things are always going to be the best, it seems like. Remember that kids' heart rates are generally going to be higher. So tachycardia for them might be super high for us. Anything less than 60 beats a minute, we're starting CPR on a child because we're assuming they are going to continue to decompensate. 60 beats a minute with poor perfusion. We start CPR. You'll see that. I shouldn't necessarily, you will see it, but in labor and delivery, I had a kid that was born. Heart rate was I think in the 40s. They tried rubbing him. They tried all that. They started CPR within 15 seconds. The kid had like perked back up and was crying and everything like that. I remember asking one of the nurses, I was like, is that normal? As I'm sitting there traumatized. And she's like, it actually happens more often than you think. She's like, we're not doing it because their heart stopped beating it. We're doing it to kind of shock their heart and it'll, in hopes that it'll kind of take off on its own. Well, she did a good job of shocking my heart, let me tell you that. AVPU, right? Alert, verbal, painful, unresponsive. Use this in conjunction with the kid's age, or use it based on the kid's age. You know, what's alert for a kid that's a newborn? What is normal for a newborn is what you're going to base it off of. What does a newborn say? Nothing. They can't. They're not, you know, painful. Withdraws. Do they make sounds? Do they cry? That's probably going to be, that's where what I'm getting at is this scale isn't always accurate 100% to a T. That's why I try to find out what normal is and go based off of what normal is. Pediatric GCS, way different than adult. We still have 456, EVM 456, how I remember it, eye-opening, verbal, motor, EVM, and then 456. What you'll see in our verbal components, we now have coos and babbles, cries. This is kind of important, hint, that you know, so whether you got to take a picture of that or not. Exposure. So when we talk about exposure, we're talking about looking for underneath clothing, right? We're talking about a quick, rapid exam of things that could be causing what the patient or the parents are complaining of, or at least a partial clothing removal, just of the affected area. Rapid exam, looking for any, you know, potential injuries or anatomic abnormalities, and then kind of wrapping them back up because we want to try to avoid that heat loss. Transport decision. Again, is this a stay and play? Is this a serious issue? What is our mechanism, or what is our nature of illness? What are we dealing with? History taking, again, it's going to be kind of hard on kids, and they might not have a really big, significant medical history. But the parents obviously can be answering any questions for them. Get as much as you can. Maybe they're on maybe they're on Tylenol or something like that for a fever. But other than that, you're not going to get a whole lot of information, and that's okay. Secondary assessment. This could be a full body examination. Complete set of vital signs, right? We want to get their baseline vitals at this point as well, if we haven't already. Look for the extent of what's going on, whether it be nature of illness or mechanism. If it's a medical issue, then we're looking for what systems, respiratory, cardiac. If it's a trauma, then we're looking at specific regions that you see listed there, and we're looking for bruising, swelling, any sort of cuts, lacerations. And again, pay attention to fontanelles in our infants. I mean, that kind of makes a difference. You know, that tells us dehydration, that tells us brain swelling, that tells us, you know, potential meningitis. It could also tell us intracranial bleeding, to be honest. Normal blood pressures for kids. All right. I think it was my PEDS, one of my PEDS rotations. I had one of the doctors ask me, hey, what's the minimum allowable blood pressure that I should see with this kid? And I was like, I don't know. I was like, how old is the kid? And he said 12. And I remember thinking, I was like, I don't know what this guy wants from me. I don't know what he's expecting me to say. And then for some reason, I remembered this. And I was like, 94-ish. And he kind of, you know, gave me an attaboy for it. But this actually gets used a lot more than you think. So minimum systolic blood pressure that we want to see is 70 plus 2 times the age of the kid in years. Normal, I want to say they say is 90 times 2 times the age in years. Our pain scale, our Wongbacher faces pain scale. the reason there's pictures is because obviously kids can look at pictures a little bit easier than they would 0 through 10. And you can also look at this yourself and you can say, okay, if the kid's crying severely, it's probably the worst pain they've ever felt at this point, as opposed to, the kid's happy as heck, I'm going to rate their pain as 0 or something like that. It really bases off the kid's age, to be honest, if they're really going to assess pain or be able to tell you what's wrong with pain or not. Pharmacologic interventions, I'll be honest, as far as pain for peds, whether it was a broken arm or a broken leg or something like that. I've had a lot of fractures and broken arms of kids, baseball fields, roller rinks, or whatever you want to call them. And honestly, I treated with fentanyl each time. Both times the kids responded really well to fentanyl. What started as screaming and freaking out ended with mom freaking out and the kid asking mom what was wrong with her, calmly as could be, and that just freaked the mom out even more because she knew her kid was drugged up. But fentanyl is a good choice as long as there's no allergy contradictions. Fentanyl dose for kids is the same as an adult if you're weight-based, which is 1 mic per kilo. The first time I read that, the first time I ever gave pain meds to a kid, I was like, okay, seriously? I was like, this can't be right. The protocols have to be wrong or something like that. It was the first time I remember the fentanyl dose for kids, or had to look it up. And I double checked with my friend Google, and sure as heck, 1 mic per kilo. Just remember, opioids are probably new to them. Don't give them a ton, just enough to take the edge off. Be careful again with kids because they're breathers. So any sort of respiratory depression could actually hurt them more than anything, especially if we give them too much pain meds. Watch out for any sort of hypotension. Some of those other drugs, Tylenol, sure, maybe the parents have over-the-counter Tylenol. Benzos, Versed, Versed's really good for muscle spasms, muscle pain. It can be used in conjunction with fentanyl. Nitrous oxide is something that's not a whole lot of people carry anymore. I know we still carry it. I've never used it. To be honest, I don't think it's ever been used. I think I tried to use it once and I couldn't figure out how to set it up, so I kind of just pushed it aside and gave intranasal fentanyl. But nitrous oxide is an option, and to be honest, if I knew how to work it, or maybe it's just, I don't know, a bad system or something, I'd use it more often because it's patient controlled. They're holding that to their face as opposed to a med that you can't reverse. You can, but then you allow the pain to potentially come back, and now they can't get any more payments at the hospital because you gave Narcan. Nitrous oxide is a pretty good choice. I could see it wearing kids because it's controlled, and they surely realize that the more they breathe in, the better they're going to feel, and then if they take it away, the pain starts to come back. Does anybody service on here use nitrous oxide by chance? Or have it, at least? Or seen it used?
Yeah.
Which one? You saw it, or you have it, or?
We carried it. I've never seen it used.
Yeah,
I used it back in Wisconsin, and I loved it.
and I've heard it's great. I've heard it's great to use. I could just imagine the hospital's face when I come in and say, well, they've been getting nitrous oxide for about the last 45 minutes. I think they're going to look at me like I'm nuts. But
The neatest thing, though, is like some of our servers had like flavored masks. So when they got the nitrous going in there, it was like bubblegum flavored or cherry flavored. So they didn't have that. It was like a soothing effect to them. So
I don't think that's necessarily a good thing, because then I'd be like trying to strap it on myself all the time if it was cherry flavored.
well, it just helped the kids at the time. So
It is highly abused in the dental business.
Oh, I could see that because it's not very controlled. I don't even know how to fill it, to be honest. Like to refill it if I needed to. All right, let's see. Reassessment of our kids. We all know how to reassess everybody. We're looking at our primary assessment. We're re-going over it. We're checking another set of vital signs, looking to see if any of the treatments we performed made a difference, and looking to see if this is an incident of pain we gave pain meds, maybe their pain levels come down. That's really doing a reassessment and seeing what's changed during transport. One of the things that grinds my gears is when somebody writes an EMS report, and I'm saying this because I hope that none of you ever do it. And we go from being in the patient's house in the EMS report to upon arrival at the hospital, I gave my verbal report to the nurse. Where did we miss the whole transport section in the narrative? Well, we didn't do anything during transport. No, you did. Nothing changed during transport's the difference. Documenting patient was reassessed during transport. No change noted in patient conditions. Patient didn't know any reduction in pain, stuff like that. To me, that's important because it shows you we're actually doing something instead of we're at the house, now we're at the hospital. Respiratory, again, is huge with kids. Frequently encountered. You'll come across it more than anything with kids. Just be cognizant of what you're dealing with because it can go bad really quickly if you don't intervene. As kids, I'll usually toss oxygen on them if I need to. Blow by, I do blow by on most of the kids, to be honest, just because, again, they don't like masks or little prongs up their nose. Infants specifically have a limited ability to be able to compensate for these respiratory problems. And the problem with that is they expend a ton of energy trying to breathe. And then to where the point their body just starts to shut down, as opposed to older children have kind of developed a little bit better compensation method so they can compensate for a couple days as long as they have adequate oxygen. We really need to determine at what level they are at. Distress, failure, or arrest. Remember, distress is difficulty breathing. Failure is we're starting to shut down. Arrest is we've lost all breathing capability. People think of failure as not breathing. Arrest is not breathing. Think of cardiac arrest, cardiac failure. Cardiac failure is congestive heart failure. That doesn't mean the heart isn't working. So know the difference in those ones. Distress versus failure. Distress, you're going to start to see maybe some slight color changes. You're going to start to see those accessory muscles. You're going to start to see those nasal flaring. Grunting is a big thing with peds as well. You'll start to hear grunting when they breathe. Might be a little tachycardic. As to when they start to go into respiratory failure, we're now starting to see possibly an altered mental status, decreased or absent retractions, and breaths that aren't really normal. This could be gasping, as opposed to respiratory arrest, where the patient has no respirations at all. At that point, we need to initiate, obviously, some invasive measures, whether it be just bagging them with an OPA or NPA, or going down the intubation route with them. I feel like I just went down this. No, I didn't. All right. Respiratory stress is the most common thing we're going to see. Throw oxygen on them. Throw them on blow by. It's not going to hurt anything. If it's a kid severely hypoxic, blow by probably isn't going to work because they're going to be so worked up that when they exhale, they're blowing the oxygen away from their face. But when they inhale, they'll suck a lot of it in. I don't know. It really depends on the patient, whether you're putting a mask on them or not, or having parents put a mask on them or something like that. The problem is if that kid starts to become fatigued and starts shutting down, they're not going to be able to tell you, I'm too tired to breathe, like an adult would. They're just going to go out. Obviously, supplemental O2. Cardiac monitoring if needed, IV access, airway management, up to and including intubation if need be, in my opinion. All right, off of respiration. We know that respiratory leads to all sorts of cardiac problems, so please just keep them in the back of your mind. Some sort of obstruction, maybe an aspiration, maybe the kids sucked it in while they were eating, maybe they got excited, laughed, sucked something in, who knows. Pretty common. They have a high risk of foreign body aspiration just because of small objects, small food items. Parents cut up food for them. generally like peanuts, hot dogs that are cut up, grapes, balloons. Kids like to chew on balloons for some reason, and small toys. Um, those are all things we should be concerned about, especially if the toy is something that's sharp. That's always freaked me out. There's a difference between partial airway obstruction and total obstruction. Partial airway, we're still able to move air, but we've got that stridor, as opposed to total, we've got nothing. Kid isn't breathing, kid's turning blue. You can see the kid really starting to struggle at that point. Their tongue, again, very large in comparison to the rest of their mouth and the rest of their head. That can also be an obstruction potentially if maybe they're altered or unconscious. You do what you need to keep that airway open. And this could be a medical condition. This could be croup. This could be an infection. Maybe we are looking at some sort of medication, to be honest. Does anybody know the medication we use to treat croup by chance as paramedics?
Racemic epi.
Bingo. Racemic epi. A lot of places carry racemic epi already pre-mixed. Some places don't. Just either they don't have a protocol for it or they mix up racemic epi themselves, which I'll kind of show you guys that tomorrow. Those of you that are in the skills station tomorrow, if not Thursday night. If you have to remove aspiration or obstruction from an infant, right? We're used to this. We're taught this in BLS class. 5 back slaps, 5 chest thrusts. It works, right? I mean, there's a reason we're still teaching it. You can watch videos all over YouTube of different people helping out a kid that's choking. Most of the time it's police officers. Why? Because they're the first ones there generally. It works. It truly does. What I will say is if it's a kid small enough that you are going to be putting your hand over their face, please don't cover their mouth because they're going to go take a big deep breath in and they're going to suck it right back in. You kind of want them pointing down, obviously, because you want gravity to assist you with anything that's going on. If the kid were to go unresponsive, if the child loses consciousness, we're starting CPR. 1 rescuer CPR, 30 compressions to 2 breaths. 2 rescuer, 15 to 2. The only reason the big difference and change is because, again, kids' cardiac output, we want to make sure that we're maintaining somewhat of the same pace for them. The only difference is with a potential choking, each time we give breaths, we're looking in for an object. Now, I won't put my fingers in an adult's mouth to pull something out because, for one, I like my fingers. I don't want to lose any of them. A child, I don't know. I might. It depends on how many teeth they have. If I see the obstruction, if you can see it, get it out. I don't care if you use a McGill forceps, if you have pliers. I don't care what it is. Do what you have to get it out of there. Heimlich maneuver. If the kid is large enough that you can do the Heimlich maneuver, absolutely. But again, remember that if they go unresponsive, we're starting CPR. If a kid goes unresponsive and you can see the object, potential. I mean, you have the potential to do direct visualization with a laryngoscope and pull out the object. That's always an option as well. I think I showed you guys that night. Watch a video of them. The guy choking, unresponsive. They put the laryngoscope in his mouth like they were going to intubate him. Put forceps in, pulled out a piece of steak, and the guy started coming to almost immediately. So it's because he got that rush of oxygen. Anaphylaxis in kids. Huge concern, right? Because we have a potential for airway swelling. Airway swelling in an airway that's already small is a little scary, right? Okay, pop quiz. What's our dose of epinephrine 1-to-1 for pediatrics? Anybody?
0.01 per kilo.
Okay, what's a quick way to know?
0.15 to 0.3.
Okay, where'd you get that from?
EpiPen Junior.
There you go, bingo. EpiPens. EpiPen Juniors are 0.15 to 0.3 for a dose. You can go the 0.01 route per kilo. Please, 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 if you're going to give epinephrine, IM epinephrine is always 1-to-1. IV epinephrine is always 1-to-10, just because of the dilution. If you give 1-to-1 IV, you're going to cause severe side effects and severe issues with the kid that's really going to be, the benefit isn't worth the reward at that point. IM is always 1 to 1. IV is always a 1 to 10. Foods is a big one with kids. Remember, they don't know their allergies. Parents might not even know their allergies. They might not know what they're allergic to. Food is going to be a pretty common one because that's what they're going to come in contact with most of the time. Generally, it's not going to be a plant or something like that. And it could be something as simple as nuts, eggs, milk. Bee stings is still a concern as well if the kid goes outside or something like that. Could be medications. Maybe the kid was recently sick. It could be something such as like antibiotics. So we're going to be asking a lot of questions. Remember, don't delay treatment. Don't delay treatment. If somebody's having an anaphylactic reaction, we have airway compromise, give them epi, and then we can go through our assessment. Hives, correct. The true name for hives, urticaria, is the true name for hives. Swelling of the lips, you might start to begin to see some cyanosis around the mouth as well develop. Over time, the kid might develop some mottling. Anaphylaxis is going to progress really quickly. It's not something that's going to last over 90 minutes. That brings me to another point. The reason I say that is on your final from last semester, one of the last questions that I put in there was a question that I typed, and it was, you were kind of on the fence about an allergic reaction versus a difficulty breathing or asthma attack. That's what it was. And I put that the patient had been experiencing this. I want to say it was like 20 minutes or 25, 30 minutes or something like that. Generally, an allergic reaction with anaphylaxis is not going to take that long. You're talking 30 to 90 seconds before you get total airway closure, potentially. Just really depends on the severity and how allergic they are to something. So that's the only reason I really brought that up. Anaphylaxis, obviously, true anaphylaxis is emergency. Epinephrine should be our first thing that we're going to, especially if there was airway compromise, difficulty breathing, whatever it might be. Benadryl. Absolutely. I don't even know my peds dose for Benadryl. That's fine. We can look that stuff up. Know your dose for epi, because that's something you're going to give really quickly. Bronchodilators, albuterol and Atrovent or Duoneb. Some places will give just albuterol, and that's perfectly fine. Just make sure that you're aware of the side effects. So they're potentially going to show tachycardia with that as well. And the dose is going to be the same for a bronchodilator as for a child as it would an adult. You're 2.5 milligrams in the hopes that it will open them up a little bit. Be aware also, you might have to give it a second dose of epi just because it has a really short half-life. It's absorbed really quickly by metabolism. So just be aware that you might be giving a second dose. And also you should be questioning if they gave a dose prior to you getting there, if it's a known allergy. Croup, something we're going to commonly see in kids, viral infection of the upper airway. The thing that really differentiates croup from anything else is a barking cough. If I had a bell, I would ring a bell every time I have a national registry style question. Barking cough is always going to be croup. Stridor, so airway potential for airway closure, trouble breathing. Racemic epi, which I can't preach on that enough. If you carry racemic epi, great. If not, I'll show you how you can kind of dilute it down to make racemic epi during skills. Since this is more of an upper airway obstruction or infection, I'm a little bit concerned for airway closure. So I'm going to start treating proactively with this. Again, that's what our nebulized epi is doing. You could absolutely give a regular neb treatment. It might work. It might help out a little bit. You could humidify oxygen as well. That could work. But if need be, you might end up bagging this kid or taking the airway, to be honest, if an advanced airway is needed, if things kind of progress to that route. Epiglottitis is a serious, true emergency in kids, life-threatening condition. Most prevalent in your 2 to 7 year old range. these kids, when I say sick, are sick. So their epiglottis, they have an infection, it's swollen. What you'll notice with them, they have an increased work of breathing and they're drooling. Drooling is the telltale sign with epiglottitis because they don't have the ability to swallow because their throat hurts so bad. So instead of swallowing any mucus, they essentially drains out of their mouth just because their throat hurts so bad. The problem with epiglottitis is that since that epiglottis is so swollen, there's a fear that it will totally cover the tracheal opening. I remember my instructor told me, if you have a kid with suspected epiglottitis, if they want to drive the ambulance, you let them drive the ambulance. The worst thing you can do is let them cry, because when they're going to start to cry, what do? You suck in really hard, especially when you're a kid. You suck in really hard. Well, what's my fear? That epiglottis is going to cover that tracheal opening. And at that point, you've only got a couple options, and one of them being a needle crike, unfortunately. The quickest thing that you can do is get them to the hospital. There is no treatment that we are going to give that is going to help epiglottitis at all. You need to get them to the hospital and you need to be ready to intubate them if things go south. Kid that's drooling like that loses the airway or potential for airway loss or starts to go out, you better get the tube quick, because if that airway shuts, you're kind of doomed, to be honest. And what the hospital does is they're going to go in and put a surgical airway in if you get the kid there in time before coding them, to be honest. Don't do anything that's going to piss this kid off. Please don't stick them with an IV. Don't do any of that. Because again, I want to keep them calm. Don't try to look in their mouth. Just don't even mess with them. Put them on your cot, buckle them in. Don't make them laugh. I don't care if you sit there and just stare at each other the whole time you're going there. Have parents keep them calm. Give them an iPad to watch TV or something. I don't care. Give them your phone with the TV on it, whatever it might be. I don't care. Asthma, most common childhood illness that we'll run into. Obviously we have lower airway bronchospasms, excessive mucus production, potential for airway inflammation. Generally, parents will know that the kid has asthma. Things that kind of will trigger it, obviously, allergies, exposure to severe colds. When I say colds, I'm talking like winter weather. Changes in the weather, changes in the seasons can affect asthma as well. Secondhand smoke's a big one. The big thing that we're going to see with asthma is that wheezing. And again, parents will generally know if their child has had a problem with this in the past. I think I was super young when I got my first nebulizer at home. So just some things to watch out for, to be honest. Watch their position too as a kid. Are they tripoding, sitting forward? And that's not anything they're meaning to do. It's just your natural reaction is I lean forward. It's easier for me to breathe. What do they look like? What's their color? Are they bluish, cyanotic a little bit? What is their respiratory rate? A neb treatment works wonders on these kids. But again, you might have to repeat those as needed just to help them out. Dose albuterol, again, 2.5 milligrams. If you're going to give them a duoneb, it's still the same 2.5 milligrams. The only thing is you add 0.5 milligrams of atrovent or ipratropium bromide. Repeat as needed. You could consider maybe giving a steroid. There it says dexamethasone. If you carry solumedrol, that's fine as well. Just make sure you're giving the correct dosage. If the respiratory distress or compromise is so severe that we have potential for airway closure, or again, it's based off your assessment, you can administer epinephrine, IM, kind of like you would with an EpiPen. Just, be careful of side effects and everything like that. But yeah, you can absolutely give Epi for breathing difficulties, because remember, Epi isn't just a heart medication. It's also a beta-2 agonist. Beta-2 meaning 2 lungs. So it'll open up your lungs a lot easier as well. Sometimes if it's so severe, you might see people do that, then give the neb treatment, because once it opens up their airway, the albuterol can get in there and actually dry up those secretions and open up the bronchioles like it's supposed to. RSV is more of a like a group, I would say, of different other sicknesses, if you will. Bronchiolitis, pneumonia, as you can see there. Really common in kids, generally in fall, winter season, if I remember right. Now, biggest thing with RSV is it's contagious on surfaces. Generally, if it's on somebody's hands, it dies within an hour. But indirect contact with a surface, it can last for a couple days, if I remember right, to be honest. Before, that it's no longer an issue. Incubation period for this, I want to say it's right about a week, right around 7 days. What's going to happen is and again, we're not going to be able to diagnose someone with RSV, but they go to the hospital, they're going to do an RSV, they're going to do a swab and do some testing to determine if it's RSV or not. Again, it's pretty common in kids. Early signs and symptoms, common cold. There's no, in my opinion, definitive thing that says one way or another. It's going to present like the common cold. How do we treat them? We treat their symptoms. We treat their complaints. Maybe we're giving IV fluids just for some potential for dehydration. Watch their vital signs. What are they telling you? Remember, tachycardia in kids could indicate, outside the normal region, could indicate compensation. Bronchiolitis, again, falls in the RSV family. Inflammation, swelling of the small airways. RSV is generally the common source for this, to be honest. Highest frequency generally in winter. A lot of respiratory problems happen in winter. And you're going to really see this in people 2 years or younger. Again, highly contagious. Some of the findings we'll see, you're wheezing, you will hear crackles potentially. Why crackles are a differentiating thing from anything else is crackles, remember, is like a fluid buildup or a phlegm buildup that could indicate pneumonia or bronchiolitis. So anytime you hear crackles and there's no heart history, or especially on a kid, I would start leaning towards pneumonia or bronchiolitis. Don't let your respiratory patients fall asleep if they say they're tired. They're not tired because they want to sleep. They're tired because their body is tired of breathing. At that point, we need to fix something, or we need to get invasive really quick. Greatest risk for respiratory failure in some patients is generally in the first couple months of life, when they potentially get a new infection or a new sickness, especially in our preemies that don't have the defenses that they should. I mean, kids already at newborns don't really have the best defense as it is. Now, born prematurely, it kind of puts you at a disadvantage as well. And also, if there's any congenital issues such as heart or lung problems, we kind of want to know about that at the time. Were there any problems? Were there any complications at birth? Or were there any complications of the child during pregnancy? Those are all things that we're perfectly fine in asking. Management generally supportive. You're trying not to freak the kid out. Suction as needed. They're not going to like it, but you're trying to help them out. Supplemental O2, again, you might be doing it blow by. Epi, if needed. I mean, if you need to give epi for severe breathing problems, go for it. If you need to give albuterol, go for it. Albuterol is a great drug. It doesn't hurt anybody. Opens up the airway like it should. Pneumonia, very much along the lines of bronchiolitis, as it's an infection of the lower airway. You're going to see this a lot in kids that are around other kids, believe it or not. More viral pneumonia, I would say, and as they get older, it becomes bacterial, if I'm not mistaken. I generally have a high index of suspicion if the complaints are, abnormal breath sounds, fever, and they have a really low pulse ox. I generally start to lean towards pneumonia, plus in conjunction with my crackles. Maybe it's a kid that's old enough to tell you they're in pain. They might be exhibiting some type of chest pain. Their lungs are really hurting. To me, those are all really good signs of pneumonia. Again, treatment is going to be pretty much comfort. keeping them comfortable, putting them on oxygen, treating them with basic respiratory meds that we might have. Is that saying you're going to start an IV on them? No. I mean, I might not start an IV on them. If they don't need fluids or anything, why do I want to start an IV to piss off a kid who doesn't want an IV? I guarantee you ask any kid, hey, can I poke you with this needle? They're going to say, first of all, they're going to look at you like you're dumb. Second of all, no, you can't poke me. I don't, unless I truly have to start an IV on a kid, I try to stray away from it just because I'm creating an environment for them to get pretty pissed off, to be honest. Pertussis, the whooping cough, highly contagious, potentially deadly. Less common around here just due to vaccines and immunizations, to be honest. Similar to the common cold, but the coughing would over time become more severe and almost have like a whoop sound when they were starting to breathe in. The problem with pertussis or whooping cough was that it would be the coughing would be like so violent that you could actually see hemorrhaging either from their lower airway. You could see vomiting because they were coughing so much. But again, here in the US, we're not really going to see a whole lot of whooping cough anymore. That's what our Tdap immunization is for. Tetanus, diphtheria, I can't think what A is. P is pertussis. I'm going to jump over this because I don't feel that's something you should remember. Airway management. Not much different than adults, but we need to remember that there are some anatomy differences than adults, right? Kids have giant heads, little bodies. Adults, pretty well proportioned. So we might have to pad again under the shoulders of a child if need be. Remember, there are different sizes of OPAs and MPAs. It's not a one size fits all or one size fits most scenario. If it's a medical situation, sure, we can do a head tilt chin lift. Trauma, we're looking at a jaw thrust before we start looking at any sort of airway management. Your OPA is great just because it keeps the tongue away. And remember, kids have these giant tongues, makes suction a whole lot easier. Contraindications, gag reflex. If they're gagging, we're not putting an OPA in. We're causing more problems at that point. I'm trying to think. Oh, kids, they're hard palate, the top of the roof. Be careful putting an OPA in because, again, you can cause a little bit of trauma at the top of their mouth when you put them in. It really depends on the method that you use to put an OPA in. I go from the side and then twist. We'll say 90 degrees. Some people will essentially fully go 180 degrees rotating an OPA in. And again, that's something that maybe we'll go over Thursday night as well. If not, actually, we'll go through it with PALS and ACLS, so that's not a big deal. Make sure you're not pushing their tongue in the back of the throat when you're using OPA. It's meant to go over the tongue, please. NPAs, great. Contraindication is trauma. Any sort of facial trauma you could be a little bit concerned with. Problem is kids don't like things up their nose. And remember, kids are nose breathers. So unless they're totally unresponsive, this could be an issue. But again, we do what we have to at the point when the kid needs it. You'll actually see different services have different ways of getting oxygen to kids. Like I know one of my masks is like a little dragon. I think it's a pink dragon, to be honest, with a bag that hangs. And that way kids aren't as scared and I think it's kind of cool or whatever. I think my pediatric neb mask is the same way. It's something cheerful to kind of show them it's not as serious as it is. As you can see there, I don't know why they're using a Dixie cup. I have questions. Whatever you have to do to get that kid oxygen, to be honest, it's not gonna, whatever you do will work apparently. And here they put the cup. Oh, I can kind of see what they're doing. Instead of just holding the tubing up by the kid's mouth, they have the cup there to kind of direct the oxygen at their face. The problem is that cup, in my opinion, looks so close to your face. Why wouldn't you just do the same thing with a mask? I don't know. And I don't carry a Dixie cup or red Solo cup in the back of my ambulance. Non-breathing masks are going to freak kids out. But again, if you can get it on there without them freaking out, by all means. We want to try to maintain that 94 to 99% oxygen range. Remember, non-rebreathers were generally 10 to 15 liters per minute, high flow O2. This is the terrifying part. I know you guys have been through the skill of it. I don't think, maybe once I've had to. But it is a definitive airway, and we have a decreased risk of aspiration with these kids. The problems are there's some pre-hospital issues with intubating. Obviously, damage to teeth, oral structures. Maybe it's done incorrectly and the patient does gag due to the vagal response, the vagal stimulation. Increase in intracranial pressure. There's the risk that where you have incorrect placement. So there are some risks when it comes to tubing somebody. But we should know our indications. And again, the biggest question that people always ask is, what is the threshold for when I should know I should intubate somebody? I can't set that threshold for you. That's you setting that threshold. I know my threshold, and I know when I would do it. And it's either A, when the person's unresponsive and I think they can't maintain their own airway, or B, the patient tells me they're getting too tired to breathe. If there's a doubt in your mind on when you should intubate, I always say, if you question yourself, should I intubate this patient? The answer is probably going to be yes. Just again, remember there are differences between adult and pediatric airways. We always used to say we used uncuffed tubes, and the reason for that was they said cuffed tubes actually restricted blood flow around the trachea. That's kind of been dispelled since this point, and cuffed ET tubes are back in, even in PALS guidelines, to be honest. Use your link-based resuscitation tape, please. Don't try to second guess on what should be what. I mean, is there a method? Yeah, but if you have it available, use your tape. Now there are quick ways on different sizes, like as you would see. Let me see if I can find it. ET tube. There we go. Formula for children older than 2 years old is 4 plus age in years divided by 4. Generally, that's the size tube you would need for that child. And then it just says 4 millimeter for between 1 and 2, 3.5 up to 1. I can't say that, and I'm going back to the slide. I can't say that each blade is going to work in each patient. We use the Brosla tape as a guideline to kind of guide us in what direction we should be going in. But is there a potential that it's not going to work? Absolutely, there is. Cuffed ET tubes, it's the same formula, except it's 3.5 instead of 4. 3.5 plus age in years divided by 4 would give you your cuffed tube size. Again, we got away from uncuffed tubes because we went to them for a while saying, well, us putting air in the bulb is really restricting blood flow to the trachea. That they dispelled that now. It's not, kind of like they said tourniquets can only be on for so long before we have to cut the limb off. That's been changed as well. Not something that we're going to do very frequently, but something you could do is gastric decompression by means of a OG or an NG tube. And again, it's essentially releasing any of the gases or buildup within the stomach itself. Generally, you'll insert the nasogastric or orogastric OG or NG tube, and then hook your suction to the edge of it and suck out any contents or any sort of buildup itself. Has anybody seen one of these put in the hospital yet by chance? Or seen one put in it at all?
Yes, and you do have to put it on low suction.
Mm-hmm.
That's super important.
I was waiting for you to say something. I'm not going to say I know a whole lot about OG or NG tube insertions. I know sometimes, like you see there, I that's only from what I'd seen in the hospital, so don't take my word on it's, gold. But I've seen them attach syringes to the edge and pull something up. But what's important is us to know anatomical landmarks. Generally, you'll hold the tip at the tip of the nose. You'll guide your finger down to the earlobe. Then you measure from the earlobe to the xiphoid process. So where our pointy part of our sternum starts to go away is our xiphoid process. That's how you measure how long or how much you should be using before insertion. Now, you can see there they put mark length on the tube with tape. Sure, some people will do that because tape's readily available. They can grab it pretty quickly and just mark it on the tape at what point that should be at. I'm not going to lie. I don't know a whole lot about NG or OG tubes. Sarah, if you know any more about them, you're more than welcome to speak on them. I don't know a whole lot about them. I'm not going to lie. What were the indications that you had seen for it being used?
Yeah, and it's interesting because the nurses at the hospital are really surprised that we don't do more of this because they're like, you guys intubate. I can't believe, you guys don't do more of this.
Yeah.
Because if we've got a vomiting patient and trying to intubate and
it really takes away the risk or no, I shouldn't say total risk, but it takes some of the risk away of gastric upset when we're intubating by doing this and taking any of the, I wouldn't even say contents, we'll just call it air out of the stomach. We prevent the patient from potentially vomiting when we do it. And again, I'm not sure why we don't do it a whole lot either. It kind of seems like the things that we think are gross, we've just kind of gotten away from. But yeah, it has its place, absolutely.
I have a question. There's a spot on the ET tube that you can actually do that, right? That you can actually.
What do you mean?
When you place the tube, there's like a spot you can actually put one down.
Just right. I mean, right through the middle of the tube.
Yes. I mean.
Yeah. Yes, that's it. I mean, just. But here's the thing: that tube isn't going in their stomach. That's. I mean, you see what I'm saying? Like that ET tube's going to their lungs, not their stomach. That's going into their trachea, not their stomach.
Okay. Gotcha.
I'm trying. You're thinking of suctioning. You're thinking of tracheal suctioning.
Yeah, you're right. Sorry.
That's what I was sitting there thinking, and I got confused for a second. But yeah, very similar actually. Same. God, is it the same? It's the tube sizing is very similar. But yeah, it'd be the same procedure. I'm measuring everything. Shock. We've only got 6 more slides, guys, and I'll let you go for the night because I can tell when you guys are starting to wind down because when it starts to happen to me too, and that leaves us literally the same amount tomorrow night. Obviously, shock is when we have the true definition is hypoperfusion, lack of perfusion or inadequate delivery of oxygen and nutrients to tissues to meet the metabolic demand. It's when our body says, I need this, and we say, well, we can only give you this. Our body throws a fit and throws us into shock. 3 different types of shock, and there's classifications within each. Hypovolemic, distributive, and cardiogenic. Within distributive, we have neurogenic and we have anaphylactic. All different types of shock, right? So let's look at some of these different types. Remember, look for different signs of shock. Compensated, obviously, we're going to see an elevated heart rate, but blood pressure is maintaining. Elevated heart rate, but blood pressure is maintaining. That's a really good hallmark for compensated shock. Though pure normal, you won't really see any other signs. Decompensated, this is when, the heart is tired of beating so fast and the blood pressure is starting to drop. So you're going to start to see a heart rate slowing down and blood pressure starting to go down. That's when we start to call this decompensated. Or they could be tachycardic with blood pressure that's continuing to drop just because their heart is, again, not doing what it should be. They may have an altered appearance a little bit. Rapid rapid intervention is pretty key to this, to be honest. Whether it's just fluid bolus, remember, and with kids at 20 ml per kilo, and neonates is 10 ml per kilo for fluids. A lot of times fluids do a lot. Actually, what I'll do is I'll get through the shocks and then we'll be done. Hypovolemic shock, right? And this is common. This is kids that are sick. This is kids that, you know, haven't been taking in a lot of fluids, but have been getting rid of a lot of fluids, either through urine or, you know, or intestinal, whatever it might be. The facts are in the history with hypovolemic shock, in my opinion. Yeah, we can have hypovolemic with trauma, but that's more of a you know, bleeding internally or anything like that. But what I'm talking about is more of a medical hypovolemic shock. And that really comes from asking about the history of the kid. Have they been sick recently? Have they had a fever recently? Have they been eating like they should? Have they been, you know, have they had a bottle like they should? Have they been drinking water like they should? All these things come into play. You know, what's the color of their urine been? How frequently have they been urinating? What do their fontanelles look like? What do their eyes look like? Skin turgor. When I say skin turgor, can you grab their skin and make a tent out of it? Will the tent go away? And what is their, you know, what is their general overall appearance? I mean, do they just look sick? What is their cap refill? Remember, greater than 2 seconds concerning for an infant or a child. Main concern, in my opinion, volume replacement, keeping them warm, and stopping any bleeding if you can. Aside from that, I'm getting to the hospital. In kids, remember, their veins are a lot smaller. We might not be able to get venous access. Now, if it's so severe that we need access, then we go to access. If the kid is that sick that we have to IO them, then that's what we do. And we'll talk a little bit about more IOs in PALS. Remember, 20 mLs per kilogram for boluses. Really, you're titrating to the patient's effect, to be honest. Distributive. So again, anaphylaxis, neurogenic, septic. These are all concerns, right? This is when our body can no longer regulate the size of our blood vessels, our arteries and everything. That's when we start to go into distributive shock. This is not a pump problem and it's not a fluid problem. It is solely a pipe problem. Generally, when the pipe starts to expand because the body can't control anymore, when I say pipe, I'm talking blood vessel. What do we do? Instead, we either fix the pipe or we fill the pipe up with fluid. You know, think of anaphylaxis as you see at the bottom there. In an anaphylactic reaction, the patient is red and has hives because their blood vessels have expanded. Their blood is brought to the surface of their skin. That's why they're red in color. We give epi, we shrink the vessels back down. We've now taken that shock component out because their blood vessels they're no longer hypotensive, none of that, because their blood vessels now have an adequate amount of volume inside of them. Cardiogenic shock. Shouldn't see it that often in infants, but you absolutely can, especially if it's somebody or in a child. If it's somebody that has a congenital heart issue, yeah, that's absolutely a concern. Some rhythm disturbances could be seen. You know, this is a pump problem. With shock, I always say pump, pipe, or fluid. It's one of those things causing an issue. This is a heart that is sick. Treatment really doesn't change a whole lot based off of our other shocks. We're trying to maintain them. They don't need a paramedic treating them at home for 45 minutes on scene. You do what interventions you need. What they need is a doctor. What they need is a hospital. Again, remember, these kids could have heart failure, so they could have fluid buildup in their lungs. They could have pedal edema. They're going to look sick. They could be jaundiced in color. Parents will generally know if there is a heart issue. Err on the side of fluid resuscitation unless you are sure of the diagnosis. Just for the simple fact that if we keep dumping fluid, but the heart can't process it, we're doing nothing but causing issues. That fluid has to go somewhere, and a lot of times that somewhere is the lungs. So just be very careful. All right, we're going to stop there at cardiogenic shock, and then we're going to pick back up tomorrow at cardiovascular emergencies with kids. Let me see here. All right. What questions can I answer for you guys? Like I said, it wasn't a ton of new knowledge. A lot of it is stuff that we already know, but some of the things changed, like medication dosages and, you know, assessment findings with kids and whatever it may be. Tanya, yeah, go ahead.
So we just went over chapter 4. Is that what it is?
Yes, yes.
Okay. Anything before that we needed to go, or are we just kind of skipping around?
No, actually, has anybody gotten into Canvas yet by chance?
Yes.
Has anybody else?
Yep.
Okay.
Yeah, but it doesn't look like you can see a syllabus or anything like that.
Yeah, there's a syllabus there. I actually got them today, and you
I was
actually have
just
to scroll
let
through
me-
different areas.
While I have you guys here, let me pull up Canvas real quick and just show you how to navigate it. And then, because I've been honestly worried about this all day, because I can't see what you guys see like I used to with D2L. So let me get my screen shared again.
I do have one question.
Yeah.
There's like a download app that we're supposed to download for like a blocker.
You don't have to.
Okay.
We're not blogging.
No, I was trying to do it, and like my computer kept couldn't do it. So like I'll just wait and talk to you tonight.
I wouldn't download it.
Okay.
I didn't download it, so I don't think you need to.
Okay.
All right, so your homepage when you get into Canvas, and the easiest way to get to Canvas, if you don't have a link for it, go to mchs.edu. Under students, it has a link to Canvas, and you just log in with your normal D2L login. The homepage, like this is 160.02, which is the class we're in now. This is your homepage. The homepage won't change. I'm not putting notes on there or anything. That would be under our announcement section there on your panel on the left. But under homepage, I kind of have what we're covering and when we're covering it. There is no week 8. I just put that in here because I had no other spot to put it. But let's just say, like it says, where would you like to go? So getting started, we'll have the course description, the outcomes, and then it has a link that you can click for the syllabus that will take you right to my syllabus for the class. If you go back home, week 1, pediatric emergencies, kind of gives you an overview. There is a handout that I put up there. I know that we had done for previous chapters as well. Chapter 4, volume 5, there's 2 different PowerPoints I gave you to review. One is the one I just went over, and one is the one out of your book as well. But yes, it is chapter 4, volume 5. I'll have all the week outcomes on here. If there is homework, which there is not homework at all this semester in my class for you guys, it would be listed there under each week. Like the introduction to pediatric advanced life support. So there's your introduction at the top, things that need to be done, PALS update, pediatric algorithms. So I put the cardiac arrest algorithm, the tachycardia one, the bradycardia one, and then we'll do skills or scenarios and skills during your PALS test itself. It's actually a pretty straightforward software. I mean, building it sucked, but it was because it was built from the beginning. But you guys shouldn't have any issues on your end. Did your guys look similar when you logged in here? Anybody?
Yeah.
Yes.
Yes.
There is this chat feature. I put a message in there earlier just to see if the chat works. I'm not sure. If it does and you see it, just respond to me so I know it works. If you click under modules, this is essentially files and everything that I've uploaded as well. So like week 1, pediatric emergencies, this is where you can find the chapter 4 handout. Week 2, you can see the algorithms. But on the overview for each week, I also link to them. So when you click the words, it'll take you right to that file. Mercy does have now an acknowledge the course syllabus and policy. So it's something it's a 2-question test that you've read the course syllabus and you've read the course and the college policies that you have to acknowledge. There is no grade for it, although it says it's a graded exam. There is no grading for it. I'm not going to hold you accountable or anything like that. Course policies and expectations are there. Course resources, if you ever get lost with something with Canvas. Teams, I mean, it has pretty much everything in here. And then it really, you've got to play around with it. Let me exit the student view and then I'll show you the field one. Yeah. So field is very similar, just along the same lines. Clinical is going to be the exact same, except I don't have weeks listed here. I just have the paperwork you'll need. Apparently I don't have a syllabus either. Oh yeah, it is right there. I have to link it. But I just have the forms you'll need for field itself. Other than that, you shouldn't be messing around in there a whole lot. But you're more than welcome to look around. And if you have questions about something, please contact me. And like I said, if I can't find the answer for it, I'll or if I don't have the answer, I will try to find it for you because it's a learning curve for us as well. So. Any other questions? Anybody?
I just have one question, Rudy, and I didn't
Yes,
think
sir.
of it until just a little bit ago.
Yeah.
Okay, kids that have croup, how often do they like actually crash and require airway management? Because I feel like most of the kids that I see that have croup like are fine, and it was just like the parents freaking a little bit. But how often is it?
But I've also I've only seen one, and it was when I worked for hospital-based EMS. What parents brought in this kid, and I mean he just like horribly whooping cough, like horrible barking cough, and the kid actually. I'm trying to remember back. It was like 8 or 9 years ago. I can't remember if they intubated the kid first or what, but the kid actually went into cardiac arrest, and that was the only one I've seen like that. Now the problem is, since I've seen that, I can get nervous with all croup patients, or what I suspect of croup. Are they majority of them fine? Yes, they absolutely are. But just knowing that if things go downhill, you have the tools available to fix them is really, I think, mainly what they're getting at. But yeah, majority of them I'd say are going to be pretty much pretty. They're going to be sick. Don't get me wrong, but I don't think it's going to be the point that we're intubating them. But again, it can happen. Anything's possible. If that answered your question.
Yeah.
Anybody else? Tanya, I can't tell if are you asking another question or is your hand still up from the other one? Okay, there's my answer.
Nope.
All right. If you guys don't have any questions for me, I'm excited for this semester. It's an easy semester for you guys. And that's what I like. It's enjoyable. It kind of brings everything home together for you guys. The things we cover, the things we do in skills lab, PALS and ACLS are really exciting. I really enjoy teaching those classes, as well as your other card courses. If you have questions, this is the semester to ask them. This is the semester that everything starts wrapping up. Clinical, field, ACLS and PALS will make things come together. It's funny. I was talking to actually Kyle earlier, and we were talking about ACLS, and I said, what's funny is after going through ACLS, you guys will be like, wow, the scenario you gave me in second semester, I killed that patient. Like, yeah, you did. So it really does hit some stuff home. Tanya, go ahead.
Well, my question is,
Oh, sorry. I was going to ask, are we going to be doing GG drills tomorrow, or is there information that we didn't know before we get there?
No, not that I know of. But what do you mean by GG? What do you mean by that?
GG drills, where he, just kind of bombards us with information that we haven't gotten yet.
No.
Okay.
Nope.
Good deal.
Other Tanya, did you have a question?
yes, My question for you is, do you want our new list of field time we want to do as soon as
Yes.
possible? How does it work?
Yep. Just email it to me.
Sounds good.
All right, I'm going to stop the recording. You guys have a great night. And like I said, the rest of these classes should be fairly short. So have a good night, guys.